Thank you very much for the invitation. Thanks also to my friend, Professor Kotsis. I'm really sorry I cannot be with you. Certainly, you are in a much nicer place than I am in my hospital today. But anyway, I'm happy to participate also virtually, also for updating you on the role of an important diagnostic technique, which is ambulatory blood pressure monitoring. I hope you can see my slide in a full screen mode now.
Yes, yes.
So ambulatory blood pressure monitoring is a key element in our diagnostic process. If you consider that hypertension remains the leading cause of mortality in the world, this represents a very important tool to be able to control it better. If you focus on the very recent ESH practice guidelines, just a summary of the guidelines that we published last year, you find that at the beginning of the management process, there is space for measurement. Measuring blood pressure is the first important step in hypertension management. And what is recommended by the guidelines is to improve the diagnosis through an accurate measurement, which implies accurate and repeated office measurements, but also a combination, whenever possible, with out-of-office blood pressure, including home and ambulatory. These are recommendations coming also from the very recent 2024 ESC guidelines, just published a few days ago. Ambulatory blood pressure monitoring does not give you a number. Is able to offer you a profile, and that's the major advantage. You can identify the blood pressure behavior during the day and the night. You can identify the nocturnal fall, the morning rise, the blood pressure variability, combined with heart rate information, which is very important for diagnosis. The ESH guidelines recommend ABPM to improve risk stratification in combination with office blood pressure. They also recommend its use to identify the difficult phenotypes, white-coat and mast hypertension, and also to focus on nocturnal blood pressure behavior. This approach can be very important in diagnosing resistant hypertension to exclude the false resistant situation. And the recommendation is to use devices with an upper arm cuff, automated, validated, obviously, on the Stride BP driven by Professor Stergiou, you may find information on these devices, recommending a frequency of measurement at least of 1 every 20 minutes. More specifically, the indication to ambulatory blood pressure monitoring in the ESH guidelines focus on the condition in which white-coat hypertension is more common. For example, grade 1 hypertension on office values and a marked elevation in office without organ damage. They also recommend the use for the condition where mast hypertension is more common. And these are usually people with a high normal office pressure or normal office, but with organ damage or high risk. And finally, of course, for detecting nocturnal hypertension. If you combine office and out-of-office blood pressure, you have these 4 different phenotypes. When both are elevated, is sustained hypertension. When both are normal, is the real normotension. If you have only office blood pressure elevation and the out-of-office is normal, is white-coat hypertension. And then when you have only elevation of blood pressure outside the office during daily life, and a normal office pressure, this is mast hypertension. Concerning nocturnal blood pressure monitoring, the importance of quantifying this parameter comes from the evidence of many studies that are showing that nocturnal hypertension is the best predictor of outcome. These are data from the SISTIO studies, an old study on elderly people with isolated systolic hypertension, but I'm showing this slide because at that time we had the chance to have a placebo arm. So in this group, you find that the events rate over 2 years were only weakly associated with office pressure, a bit better with daytime and 24-hour, but the best correlation was with nocturnal blood pressure, which is a very important clinical tool. Again, the guidelines recommend ABPM also to identify and study better people with an exaggerated blood pressure response to stress testing and those who show a great variability in office measurement. But when you focus on treated individuals, that's very useful because you can confirm a situation of uncontrolled or resistant hypertension that might be due to a wild caught effect. If you don't have also an elevation in ambulatory pressure, you can check the efficacy of 24-hour blood pressure control, mainly in the high-risk patients. And you can also identify the opposite situation, people having hypotension. This is mainly the case in the elderly, where we are recommending now to reduce blood pressure more intensely, but they might be prone to orthostatic hypotension. So identifying postural or postprandial hypotension in treated patients is a very important step. I want just to refer to this paper we published recently in the European Heart Journal. This is the SIM ABPM1 study, ABPM done in people prone to syncope. What we found that if you have during the recording at least one value of systolic below 90 or two values lower than 100 systolic, you may have a higher risk of stroke or syncope, sorry. And this is shown clearly in this slide with a very high specificity, having episodes of daytime hypotension in these people who are prone to syncope may identify a condition of higher risk. But we also measure blood pressure variability with APPM. This is our study many years ago. That was the first demonstrating a link between blood pressure variability and outcome. We divided people in 5 groups based on mean 24-hour blood pressure. They were intra-arterial recording. For each mean pressure group, you have 2 subgroups, the yellow and the red, respectively with a lower or higher variability. The lower panel shows the organ damage, which is increasing when there is an increase in ABPM, mean level, but within each group, the red group always has higher risk. And these are the people with the same mean pressure, but a higher variability. You can also identify the response to treatment. For example, we have a case here of a lady using a short-acting drug taken at this time. You see blood pressure is going down in the first few hours, so she might be even too much controlled, but then there is an escape, and she's no longer controlled over 24 hours. ABPM can give you this information. You can also then, so the opposite when there is a smooth reduction over the 24 hours. So having a BPM can help you a lot in managing your patients better. But if this is true, should we then use a BPM to decide on treatment? This is depending. The guidelines are suggesting, but we don't have any randomized trial telling us that if you're using a BPM to decide on treatment rather than on office pressure, you get a better outcome. We are evaluating this problem with a master study, and some colleagues are participating with us. And in spite of the difficulty due to the COVID, the study is running well, and we hope to be able to have some results in 1 year from now. The ESC guidelines, just to give you the fresh information of a few days ago, when you focus on hypertensive people with the office rating, this time recommend to diagnose hypertension based on out of office, which is a difference as compared to the ESH guideline. They're a bit more strong in suggesting use of ABPM. They provide indication of how to use it, use of validated devices with a frequency of measurement between 15 and 30 during the day, need having high quality recording, minimum of 70% of validated reading during the recording, and they keep the same threshold for diagnosing hypertension as in the ESH guideline, 130 over 80 for 24-hour pressure, 135 over 85 for daytime pressure, 120 over 70 for nocturnal blood pressure. And they also recommend use of a diary to take note of the activity that are needed to interpret the ABPM data, but also to know when the pills were taken and when there was a sleeping period during the recording. They also give us some additional information, which is, I have to say, copied from the American guidelines. They suggest some different values as a reference for the different condition, not only for hypertension. As you know, in DSC guidelines, there are different classification we have a so-called non-elevated people, non-elevated blood pressure with an office pressure lower than 120/70. We have those now defined as with elevated blood pressure between 120 and 139 systolic and 70 to 89 diastolic, and then hypertension, as I said before. They offer corresponding values for home ambulatory value, which are not based on outcome, however, but on a statistical analysis of correspondence with the office values. This is an issue, in my opinion, that should be investigated more and more in depth. They provide also indication of the advantages of ABPM, which are the same as shown in the ESH guidelines: identification of wide coat and mast hypertension, ability to measure BP in a real-life setting, having also the possibility to have prognostic data, measuring nocturnal reading, and providing information on blood pressure variability, nocturnal dipping, and other phenotypes, with a disadvantage that might be expensive, sometimes not always available, mainly in daily practice, in a general practice, and some people don't like it. Some patients don't want to repeat it because they feel it uncomfortable, many during the night sleep. Last point to conclude: if all these difficulties are related to the cuff inflation, can we now use the cuffless devices? As you know, there is a huge diffusion of these new devices now at the moment. Well, that's a difficult issue. We published with the drive of Professor Stergio this position paper within ESH, describing a different technology for measuring cuffless blood pressure, based either on sensor measuring pulse transit time, pulse wave analysis on the features of the pulse wave, using facial video processing with a PPG at a distance, using the sensor for oscillometry finger pressure, ultrasound or volume control. Different technology, then, or in general, do not measure blood pressure. They estimate blood pressure values based on signals derived from the sensors, and they need sometimes a calibration. So, are they useful? They hold a lot of promises. New technology, new ways to approach the problem. You can get blood pressure values without the subject aware. You don't have any cuff inflating, which is not disturbing your sleep. But they are now in the market already. And this, however, is driven more by financial reason, not by science. Why? Well, we do not have any evidence at this stage that they are accurate. The validation studies available are not reliable enough. Many of them include company people, which is not acceptable. So we need definitely to wait to use these new technologies until we have evidence that they are validated based on protocol accepted by the international community, which is now in progress at the moment. So to conclude, definitely, we are still a stealth killer to fight. You remember the report published by the World Health Organization last year that was launching a race against the stealth killer in the world, which is still the major killer, more than infectious diseases. So to improve our ability to control hypertension, the first step is to diagnose hypertension more precisely. And this includes accurate and repeated office measurement, include risk stratification, includes a proper treatment, but it also includes the ability to measure blood pressure in daily life, also during the 24 hours. This is my institution and my email. In case you need any additional information, you are all welcome to contact me anytime. And this is also a tribute to our nurses who are fighting COVID with us so strongly, and some of them lost their life, unfortunately, in those difficult years. I just want to close inviting you to join us next year in India. I'm the president, incoming president of the World Hypertension League now. We are having a World Congress of Hypertension in Chennai. It will be not exactly in February, but in early March because of local reason, but it will be a very important Congress where all the issues discussed also in your meeting will be taken up again and updated with the recent evidence. Thank you again very much for the invitation, and I hope you got something useful from my lecture.